countries, especially in our region, atypical posterior fracture. That tells you how great the situation is. That tells you, that gives you an idea of the magnitude of the problem. I think we're all overlooking the issue of osteoporosis. We're just overlooking it. We're not giving it. We're not paying enough attention. Okay. Are we going to improve? I think the more fragile their bones become and the more susceptible. So, hardly at all. Any woman with bad osteoporosis, they just didn't live long enough. Now, it's 80%. That is you can reduce fracture risk by 50%. The $18 billion can go down to $9 billion. That's a lot of money. But also think of the mortality. The 20% are going to die after sustaining a fracture. The 50% are going to become disabled. Think of that. If you can reduce that by 50%, you've done a great job. Let's see how we can have. After we diagnose, if you end up vulnerable content, but you really, I'm not a big fan of neural markers. They do not really, results do not go hand in hand with the histomorphometry. And way to go. But what do we offer our patients? We offer them imaging. And I'm glad, being a radiologist, that patients are coming to us to seek our help, and we can offer that help. So imaging is really, I will reiterate what I just said. Why are we so keen to put our message across that we can help? Because now, so we need to identify the individuals who are most at risk of fractures and requiring therapy to reduce the fracture risk. And we need to know that we've given the right treatment, we've given the right dose. If not, let's change. If not, what's the point of spending the money? You need something to help us tell us. Now that we have a treatment, first we need to justify giving that treatment by picking the proper individuals at risk, and imaging can help you with that. And then we need to monitor the effectiveness. Based on my preference, it's the three main. You can all remember when you have an X-ray of the spine or the limb, and you look at the bones and you say, using quantitative computed tomography and MR perfusion. I'll talk about it. You can all recognize this. Like you have the verticalization of the trabeculae. I'll tell you, because we've lost the horizontals. Losing the horizontal trabeculae makes the vertex stand up, and then verticalization of the vertebrae. The SING, femoral osteoporosis index, where we monitor the disappearance of the trabeculae in the presbyopia. It's a pretty, I would say, it's a pretty smart way of classifying osteoporosis, but I think this one. Sorry? So you're good. So what was conventional density? By 30% reduction, you're very much into osteoporosis. For 2013, how many years? 1970s. That's when we first started seeing enough applications to allow for good use of the modalities and good use. There were no specific body parts to be scanned, and we did not, most importantly, have a reference range for doing our, to do a good consistent protocol to do our scans on. So 1970s, that traverses the body and is picked up by bandages or the emerging growths of the soft tissues and the bone. This is expressed as ground accordingly. The point that I want to make is it's an X-ray technique, but it hardly at all is an X-ray. It is how we're using it. Measures EMD in the central, preference skeletal size. But if you're at risk, you would have to go to a test. It's good to do it if it's free, like a lot of the companies do. They promote their products. you're talking about maybe 2,000 dirhams a month. So you really need to justify things and drugs, and you need to follow. You have a very clear plan. Who to offer next? And the two limbs are connected by the vertical limb of the C, and from the bone. The bone mineral density is calculated and sent to the computers, where it is plotted against data from the reference population, and we get a T-score and a Z-score. I'll explain this fully to those who really want to know. And I think it's important to understand this. Casey?
It's the most sensitive. It deals with the hemorrhage and the deoxyribonucleic micropopulations. So, this is a microhemorrhage. And here what you see is a phenotypic image. This is a very abnormality. And when you put on an SW, this is classical of the deoxyribonucleic. Kind of whether the quality is there's some amount of fluid or something around it. Just put it, you get nothing to give, nothing to do anything. Let the patient see there, don't take anything. So rather show and achieve information. What we see on a video, the prototype process is sometimes this condition or this line for edema. I think this is one, this is a association of intervention is very recent. You can see that is when paralysis, aquatic paralysis, and patient has a long secondary one of the recovery. On an average, what criteria will be in day out is an intense cord signal, signal abnormality more than 1 vertical level, hemorrhage in the chronic cases. We need to answer this question. Changes seen on MRI, whether they are progressive damage to the cord, sequel is what is this is classical cyst, post-traumatic, hypoactive, injury in the cord. Pseudoconvulsions is a new is a breaking excess injuries or stab injuries, along with injuries on that. And this is one of the very frequent images, MR spectroscopy, function MRI, nothing much was seen. But they are both produced in the video image is 1000 p values was done, and immediately you see such a big long right segment. This is what is called a restricted diffusion.
And Santana. She's BDS and PS Oral Medicine and Maxillofacial Radiology Department of OMRD College of Dental Science, Medical University here at UAE. She's working as a full-time academician for the past 11 years. Registered postgraduate guide since 2002. Has many national and international published papers. Dr. Santana is involved in many ongoing research activities. Areas of interest include oral mucosal lesions, diagnosis and management, forensic odontology, and oral.
So we don't use therapeutic radiation. We use only diagnostic radiation, and we use a machine in the diagnosis itself, in the operating field itself. We use the diagnostic machine, which has a maximum favorable view since it's heavily neglected. People walk in, walk out, anywhere it is placed, and because it's very small, you don't have to worry. I've seen many of my dental colleagues holding the dental film while doing the exposure. I call them terrorists. Don't spoil your progeny, don't spoil your gene pool. But still, it's not being the protocols. We in the therapeutic itself, before getting her introduced into the clinical operating field, we are being taught radiation physics, radiation biology, radiation health physics. But none of the radiologists or even the oral radiologists, except oral radiologists, none of the dentists follow the radiation production protocols. They still keep the X-ray machine attached to the working chair. More than 48 grams. And occupation exposure, it turns around, they have averagely comes to like 7.2 millisieverts. And when you combine this with a natural, we have to calculate along with the radiographs, dental radiographs, small radiographs. Even this background radiation has to be calculated. And basically the same radiation biology, Either it could be a somatic effect or it could be a genetic effect. Somatic effect is direct dermatitis, vascular changes after being malignant. But that's a genetic effect. But all these changes, there is a possibility it's seen. It's seen that the changes are seen in a patient. But whereas the genetic effects, which
from the Health Communications Division, it's my proud privilege to welcome each one of you and especially thank our Provost, Professor Geeta Shokraj, who has agreed to be with us this morning to do the honors for all the invited speakers. We are so very grateful to each one of you and especially to the invited faculty who have accepted the invitation on behalf of the Department of Diagnostic Imaging, GMC Hospital, to come and participate in this conference. Madam, with your permission, I am so very proud to announce that this is the 200th event being conducted officially, which is recorded at the university. So we are so proud that you are all part of this 200th scientific program being held at the Gulf Medical University today. So thanks to the direction and the guidance of you, ma'am. I'm so happy. And to begin with, I'd like to request the invited speakers of this conference to please come on stage to receive a token of our gratitude and a very big thanks. So may I request our Provost to please come on stage to do the honors.
It's a great pleasure to welcome you all to the Gulf Medical University. Today it is the turn of Radiology Department. We have Dr. Tariq here, who has been very active in organizing this event for all of you. I can see he has put together a portfolio of almost 7 presentations today, representing current areas of interest in radiology, and I'm sure we will all benefit individually and professionally from these presentations. And we will talk something related to your discipline. I'm always happy to be a member of the medical and health fraternity.
May I now call upon the speakers, Professor Muhammad Saeed Hamid, who is the Dean, College of Dentistry, and the Professor of Oral and Maxillofacial Surgery, who just spoke this morning on the role of X-ray in maxillofacial trauma. Professor Muhammad Saeed Hamid. It's my pleasure to invite. May I now request all this speaking with us, and God bless you all.
For his talk about updates in fetal echocardiography. Dr. Ahmed is actually radiology Faculty of Medicine at Nahid University in Baghdad. He's board certified FRCR PhD, fellowship in fetal cardiology from Thomas Jefferson University, Philadelphia, USA. Please.
Identify the value of fetal echocardiography in their practice every day. You should understand what are the basics for fetal echocardiography, but the most important, you should have a full knowledge of the 4-chamber view, which is the basic standard for every examination, and then I have some introduction to the new techniques and advances in fetal echocardiography. The common question usually we ask by colleagues and even by the patients, why fetal echocardiography? What is the value of fetal echocardiography? We know that congenital heart disease, represents about roughly about 1% of all anomalies of the fetus, and if we include the minor anomalies like bicuspid aortic valve, which is not significant, the number will be up to 5%. So it is a significant part of anomalies. And in the WHO status, more than 42% of the infantes are related to cardiac defect. That's one. The second point, the majority of congenital heart diseases are not presented in high-risk ladies that are dark, and you will concentrate only on high-risk people. Most of the cases they are presented in low or even non-risk ladies. So it is valuable that everyone should know some the management of the case or the outcome. Yeah. Prenatal diagnosis can improve the survival. That's one. So this is a very important point. Also, when I draw a line, I didn't see any puzzle to the left side of the line. Both puzzles to the right side. One is posterior, the other one is anterior. What is this? Then I retrieve my image. What is the normal line? This is the normal. I should have one puzzle to the left of the midline. Posterior to one side of the midline. This is right isomerism. Posterior to the other side of posterior. This is the left isomerism. It's very simple. Before. Two-thirds position on the substructure here, just to the left side of the heart. So, you know, this is one of the points in fetal echocardiogram. If you go to the adult echocardiogram menus, to start to do that. Like the intervention center, maximum before it was 12 in the new criteria, it is up to 10 minutes. But it is not the same story in the fetus. So you should go to there are two ways to solve this problem. One way, they will install these programs in the machine report. So this way you can, but simply you go just to the table, because till now the machine doesn't tell you that this is normal or abnormal. And there is no rounding, so I can say this is. And the other thing, usually, this is called the sequential technique. Like we have in the screening in the first year, between the maxilla and the frontal bone. So now we have 5 criteria in the first trimester screening. Now we have first trimester screening. In addition, we can do first trimester scan. That time you can recommend it at 22 or 23 weeks because you did weeks. So we have 2 types. Now there's too much talk about first trimester fetal echocardiography. That will be standard in the near future. I think so.
Ultrasonography of the bowel. Dr. Ravi Erasmi is very well known in ultrasound. After a stint as a faculty in various medical colleges and clinics in India, Dr. Ravi is presently working as a specialist in radiology at Emirates International Hospital in Dhaka.
Mobile disorders are found on sonography. Targeted investigations like barium, CT, endoscopy or biopsy can be performed by saving patients time and money, as well as avoiding patient exposure to the patient to unnecessary radiation and intubation. There are many advantages of ultrasound, as we all know. It's non-invasive, there is no need of IV contrast administration, it's real time. You can see peristalsis in ultrasound, so it is very useful in GIT ultrasound, water injection, compression, and performed after standard examination of other organs. It begins with terminalia that examination can be blank or focused. You see the gastric wall is thicker here. However, the layered structure is very well preserved here. So in the case of carcinoma, serious carcinoma of the stomach, the wall is thicker. Surroundings are very important, and those can give us clue to identify the pathology. Brief and anatomy of this.